So it is what is a VAC? What is a subatmospheric negative pressure drains out the inflammatory fluid, the necrotic products, the bacteria through the open cells of double-layered foam. And this has really helped all the injury patient to heal up faster. Infection is reduced. The number of plastic procedures are reduced so that the patient can go earlier. So these are the things which we need to do. How VAC function is, the first is inflammatory edema is cleared, which is very important. Like rods of debridements are required to remove this. This only thing which VAC clears is prevent desiccation of the drawing the fluid from inside. That's very important. Then enhances the healthy granulation tissue, the proliferation. No cross-secondary infection in wards. The wound is perfectly sealed because we need to create a vacuum so that the suction tube can suck it. And dressings are open inside the OR, not the wards. That is very important. Otherwise, do a VAC and next day if you want to change it, you change in a ward, that's not going to help you. So you have to, everything you should be done in a OR rather than anywhere else. These are some of the cases we can do these. All these plastic surgery procedures are afterwards are required, but earlier are as fast as go, you can go at the plastic surgeon covers. So wound heals significantly quicker, decrease clinical wound infection as bacteria are drained out, and effect within 1 to 2-3 days. So again, we will not go into our institute. Almost all injuries are vacced and sealed. So that more than 300, 400 cases now with the 8 machines working on. Because we need to have more machines, because you just can't do with the one machine. Because one machine will not only sufficient for one person, not that. So if you have 5, 6 patients, so he will have to wait for the turn, and that will give lots of problems. So you need to invest in good machines that will in turn will give you better results. So infection delays the healing. So VAC reduces the bacterial load. That's the main thing. So multiple dressings is equal to 1 VAC. So earlier healing reduces the number of dressings. So 2 theories of, one is Elizarov theory, which mechanically drains inflammatory fluid. The Elizarov theory is the traction on the tissues will give you a reduce, and possibility both can act. So traction on tissues, distraction, histogenesis is early granulation tissue by the cell proliferation. And you see, after putting a VAC, you'll get lots of bleeding. So that is angiogenesis, improves the microcirculation. And eventually the new venules and areoles are open up and the new growth factors are released, and so that it will give you a better environment for further plastic surgical procedures. So microstrain is the cellular level, improves the exudate and interstitial level, reduces the bacterial load. So visibly you can see a sponge collapse. Once you start the machine, you can see the sponge is collapsed. That's very important. If you don't, that sponge is not collapsed, that means the suction which is not working. So evenly distributed negative pressure, so removes exudates. So bioocclusive dressing with less labor intensive. So patient comfort is acceptance. The earlier wound healing and VAC dressing change every 2 to 5 days, depends upon your contamination. So the portable device patient can take home as well, but we don't allow, otherwise you will not come back. Safe and efficacious, is a cost effective, no complications, and the effect will be more than 2-3 days. So application is simple, the benefits are profound. So what are the indications of VAC? The primary indications are any open injury, the fasciotomy mostly, the infected wounds, the chronic osteomyelitis, chronic non-healing diabetic foot, diabetic ulcers, and amputation stumps, non-stitchable wounds, especially in the calcaneus or in proximal tibia. Sometimes you may not be able to give a primary closure at the day 1, so you can wait, we put a VAC, it reduces the edema, the skin becomes very good, and then you can give a secondary suturing. So surgical indications, so will not go, I'll go a little bit faster, so that other cardiothoracic also can use it. Contraindications are mostly necrotic tissue. If it is more necrotic tissue, then the skin that becomes more problem. So exposed blood vessels, undernourished patients, whether the skin is also, so excavation of the macerated skin can cause problems. So discomfort and malignant wounds are contraindicated for VAC. So this is a technique. I will not spare a little bit time. So this is a video. I don't know whether it is working. No. So now it was initially it started with sample section. Then we started developing our own machine, which will have a softwares to get a good timer. We can have an intermittent type of vac so that patient will not get a continuous suction, will not have, there is a blockage if you don't get better suction. So timer and software is very important. Now all these machines are software based, timer based, so the comfort of the patient, and it also gives some sound. So in the night patient can just shut off and just get sleep, so that other patient also should get sleep. So it is a timer which should be very programmed. So alarm system, if it is leaking, if it is blockage, everything will give. The vacuum pump is sucked, then we'll have so built-in alarm system and self-diagnosing, self-calibrated machines are now there, developed there. So newer models will give you newer things. So intermittent or continuous, intermittent is preferred because the continuous suction can drain out more, so patient have lots of problem. So constant monitoring is required if you are doing constant suction. So Indian suctions are very dangerous, their pressure is very high. So what is the standard procedure is minus 125 HD, range is minus 25 to minus 4 to 40, and neonates as per the age, the wound, the other parameters also give the effect on the pressure of the hip. The more the negative pressure, more you will get the pain. So that is the reason we have to have an intermittent pressure. So open fractures will give a trauma contamination, the damaged tissue, then inflammatory cytokinins. Again, this cycle will go on so that it reduces the, so mantra is fix and cover. So you give immediate stabilization and then external fixator, and then you can start a vac on this machine. So avoids fix and flap, vac early healthy granulation tissue, early closure by suturing the graft, complicated flats may be avoided, maybe avoid the plastic surgeon. Niyati, sorry about that. So open fracture, vac acts temporary coverage of the wounds when primary closure not advisable. Ideal interval coverage, so covers most muscles, tendons, implants, bones. So whenever you feel like going. So this case, this girl, a young girl was run over by the train. So initially it was done vac, then skin graft, and then everything is fine. So she walked in. So after 15 days, initially there were inches all to fixator. So after 10 weeks, Elizor external fixator was removed, interlocking nailing was done, and fracture united with the heel. It's not moving. Okay. So post-operative draining wounds, when there is a unable to catch, especially when the calcaneus, if you see this patient, all right. So whenever there is a possibility of a wound is not able to close, then you can put this vac with the suction, and then you can secondary suturing it later date. So that is a very good method, because lots of problem will occur once you have a very high tension and give a sutures on the wound, especially the precarious blood supply where the calcaneus, proximal tibia, all these areas where you need to have a very proper skin cover. So frank post-operative infection, the debrided, you can AB beads and vac. So Weber used in acutely infected THR and TKRs also with the satisfactory results. This was a patient came to us with infected non-Indian. We drained a lot of pus next day, and we put the beads and then vac it and then close it, and that will solve the problems. So whether to use a vac with antibiotic beads, which is a controversial thing, because whatever the antibiotics is leaching out will be sucked by the that machine or the vac. So antibiotics is lost. But initially we thought that it was there, but now we have seen that it is much more helpful also. Some antibiotic may be sucked out, doesn't matter, but whatever is there inside, which will also help to get the cure of infection. So 5 minutes interval is effective. So we are now using with the antibiotics with the vac as well. So dynamic surgical dressing is IVAC. It is now coming with the vac with the primary closure. So high-risk surgical wounds, which already tibial plateau, calcaneus, pilon, previously irradiated tissues with morbid obesity, THR, TKR, prior operated tissues where you want to do a system. So advantage of dynamic surgical VAC is acutely decompresses the edema, hematoma, sucks the edemas and maintains the surgical wound as it is closed and assures healing. Especially it is good for the fasciotomies where you want to have a little time to give a closure to that and wait till the good granulation tissue is formed. Here the VAC is a really boon to all the orthopedic surgeons, so that eventually after that the plastic surgeon will be happy to see the healthy granulation tissue on before doing any plastic covers. Another very difficult task is the diabetic foot patients. They are a very, very bad skins and people, they don't want to get amputation. So we can try this before give a last resort of amputation. Third is very commonly is the infected amputation stumps, also very commonly seen the osteomyelitis and compound when there is a vascular repair or a failed or whatever vascular injury is unsolvable, gangrene, and then you can have this when it is not able to close the wound, you can have the VAC very, very, very effective. So complications are overgrowth granulation tissue, it causes lots of pain, it can cause hematoma. The skin is the big problem for, especially when there is a foot and infants, dehydrated patients, and failure wound to respond is also very common. So sometimes it can cause problems if you don't monitor it properly. So device malfunction can occur, backflow in low volume suctions, but nowadays that is gone. High negative pressure with large canisters, the excessive suction, and it's nowadays Indian canisters are available disposable, but it's quite expensive for the patients. But those who are imported ones, they are very expensive. But our Indian have started manufacturing, which is a disposable, which costs 900 rupees per patient. So it is not good. So it is good to have a VAC. So Cochrane Review Library also have good level studies, and so we'll not go into the discussion about. Now the conclusion is use VAC. That's very simple. Is everywhere, whenever you feel like there is a wound is there and you want to have better earlier, get a debride. There is no shortcut for debridement. There is no role of without debridement you cannot put a VAC. It's a simple and computerized model, and you can use any of those available. So use a VAC very judiciously, and you must use that and put the sponge in the OR, not in the ward or in a trolley in somewhere around the corridors of the hospital. But you must take it to the OR and then change in a sterile conditions, you must change the VAC sponge and then change it. Thank you very much.